to, I think it is, depending on, it's the slide that says pepsinogen. Okay, so pepsinogen is created where? Nope. Angiotensin is created there. Wrong one. Stomach, yeah, what are we talking about? Come on, guys. It's a guess, right? Yes, stomach, esophagus, or mouth, and that's all we talked about so far, and you got there, right? So, like, hold on, I'll show you. The reason I want to bring it up is because pepsinogen is an inactive form of an enzyme. What is the term for an inactive form of an enzyme? A zymogen, exactly. It's defined in here, but unfortunately it's defined in the stuff we're going to sort of skip over today and then get to later on, because a lot of what is secreted by the pancreas are zymogens, right? And so I just want to make that clear, because I think when I was talking about pepsinogen, I skipped over the fact that it is inactive and then it's activated by the hydrochloric acid and becomes pepsin. And that's what actually does the digestion of protein, okay? So a semi-important point that I don't want to glance over because I was talking about something else where I saw a butterfly and forgot to mention it. All right? Clear enough for everybody? Okay, good. Any questions about yesterday? Anybody remember yesterday? We're not talking about kidneys. It's all right. Let's get to where we're going. Huh? It is really convoluted. That's Mr. Wright's joke, isn't it? Sounds like it. All right. All right. Small intestine. So, made up of the duodenum, which is the initial part following the stomach, so it kind of does flow in the way we're going. So, what is the portion, the distal portion, if you will, of the stomach that then goes into the duodenum? The pylorus, and specifically what part? The pyloric sphincter, exactly. So the pyloric sphincter is a muscular band around the end of the stomach that allows food in and then clamps down in order to prevent backflow of contents into the stomach, right? Then from the duodenum, we go to the jejunum, which, if you've ever been kicked in the jejunum, if you've ever seen the movie, you guys seen Will Ferrell movies?
Yeah.
Kick in the jejunum, throw up, right? You got it? All right. Anybody who hasn't seen that movie, watch it. Anyway, and then we have the ileum, right? The ileum, which ends at the colon. Which portion of the colon? Anybody know? The cecum, right? Okay. So most of our digestion in earnest happens here. This is the big player. Now, the big player that creates most of the digestive juice is going to be the pancreas. We have a significant amount of what we call brush border enzymes that are made in the small intestine. We'll get to those. But again, this is where the majority of everything happens. We have crushed through mechanical digestion. That bolus of food has become chyme when it hits the gastric acid. Now that chyme is in the small intestine with a tremendous amount of surface area of that actual food that we've ingested, and now it encounters the tremendous surface area of the small intestine. So we digest and absorb the majority of our stuff here, okay? So I put this on here. This is just extra. I don't want you guys to think that you have to remember this, but if you go down here, the ileocecal valve, again, none of these valves are really true mechanical closures where there's an actual piece of tissue or something like that that physically closes off the door. The ileocecal valve is essentially this tiny little lip of tissue that has a physiologic, like an anatomic musculature around it, and this closes off. And the reason why the ileocecal valve is important is because we don't want contents that have entered the large intestine going back. We have these physiologic valves in order to prevent backflow, right? And that's what this does. But again, it's not a true, like, closure, like an eyelid or something like that. You see what I'm saying? Okay, so there is a possibility for retrograde flow. Some of you may be familiar with that. Vomit, all right? And you can vomit all the way from down there, depending on that patient. If you have a small bowel obstruction, it can go awry. Yeah. So, and in case you're wondering what AO means, that's the appendiceal orifice, that's the appendix, right? And so if you're looking at that, even though we haven't got to appendix, you can see that tiny little hole. It's a blind loop, so it's a true diverticulum. Comes off the end there, so stuff can get in there, and then really has no mechanism for which to get out, so it accumulates, it hardens, and most of the time that's the pathophysiology of appendicitis. Why doesn't it happen to everybody? I don't know. Luck of the draw, I suppose, okay? So, small intestine, we have the, like I said, duodenum. This part is retroperitoneal. It's a short part where the stomach dumps into, and then it comes around. The head of the pancreas kind of sits in that little notch there. And right where that head of the pancreas is an opening where the gallbladder stuff and the pancreas stuff that we haven't talked about yet enters the digestive tract in order to begin true digestion, real, actual chemical digestion, okay? The jejunum, sort of the middle part, it does a bunch of gee whiz stuff, and then the duodenum is, or excuse me, the ileum, again, the end, the long part, but it gets to the ileocecal, and so that is after everything we've been able to extract from it in the small intestine, brings it into the large intestine for further processing, ultimately into feces, okay? Let's talk about surgical anatomy, just some clinical correlation. The division of the upper and lower GI tract, so you'll hear upper GI, lower GI. The division point is the ligament of Treitz, the suspensory ligament of the duodenum. It's actually a muscle, but it's got ligamentous elements to it. So it's kind of a surgical anatomy gee whiz thing. But clinically, you can sort of associate patients' symptoms, what they're overtly experiencing, with where it may be coming from, right? So if a patient is throwing up bright red blood, right, or pooping bright red blood, either they're having a high degree upper GI bleed, and then if they have more black stool, black tarry stool, then you think it's coming from a lower GI section, based on the amount of time it's spent in the GI tract, how much the hemoglobin has been digested. And again, that is later on down the road, but ligament of Treitz, although it is just kind of surgical gee whiz like trivia, it does help to sort of identify where it might be coming from, all right? And that is Václav Treitz and his ligament, okay? Ligament of Treitz. All right, histology, same layers as everything else, okay? I told you those layers are going to be pretty continuous through the whole thing. It's just the tube. The only thing that really varies is the adventitia versus the serosa, right? So we have in the muscularis layer, what is in the muscularis layer? I know it says it on here, but hopefully it's been said enough times at this point. The myenteric plexus, yes. The myenteric plexus, which what does it contribute? What does it control? Movement or motility, right? Put the ends together. And then in the submucosal plexus, we have Meissner's, right? Which controls secretions, right? A lot of secretions here in the small intestine, a lot of these brush border enzymes, and also hormones that are used to activate things or control certain things as far as gastric reflexes that we're going to talk about here at the end, okay? So, picture-wise, again, same thing. This is just a section of the small intestine. It really doesn't vary all that much. But, oh, sorry, too fast. But, what's this little guy? A villi, one single villus, right? Okay, what is the real function of the villi? Increasing surface area. And then, I know you probably can't see it up here, but maybe if you're following along at home, what are these little guys? Microvilli, right? So it takes this tube that is what did I say, 10, 12 feet long, and gives it a surface. You know, if you just flay that open, if you took a piece of tube that was that long and you just cut it open, how much surface area is there? A few square meters, maybe a square meter, right? These microvilli and these villi give the small intestine approximately the surface area of a basketball court. Okay, if you extrapolate it into the actual true physical area. So what does that mean? That means that there is a ton of surface area for absorption, for secretion, to make sure that we extract everything we possibly can and get all the water out of it as possible. Most of us associate large intestine with water reabsorption, and that is true, absolutely. But the majority of the water has already been reabsorbed by the time it gets into the large intestine, right? So just understand that. The surface area contributes to that. And if you look here, where are we at? So this big yellow, usually lymphatics are green, right? But that lacteal, right? That lacteal, what is a lacteal again? This is sort of the lymph pathway in the GI tract. And what does that lymph pathway really take control of a lot? Fats, like some of those bigger, larger, fatty pieces that are too small, or too large to go into the capillaries, right? So it's an intricate structure, right? Very good. So cells-wise, histology of the mucosa, this is what's going to make most of our stuff, right? The submucosal plexus will stimulate these cells in order to make these things. Secretions, these are the secretions, okay? S cells make secretin, that's pretty nice, right? S and S. So what does secretin do? It secretes stuff, there you go, it does. It induces something to be secreted, let's say that. It increases pancreatic bicarb. And why would we need pancreatic bicarb?
Stomach's acidic.
Right. The stomach is right there. The head of the pancreas sits in that little notch of the duodenum. What is coming by in the duodenum? Fairly highly acidic content from the gastric area, right? From the stomach. Gastric area, what the hell? Anyway, you know what I mean? From the stomach, okay? And decreases hydrochloric acid production. So, has a twofold thing. One, it's going to help us prepare the rest of the GI tract for the stuff we've already eaten. And it's going to tell us that we don't need any more hydrochloric acid because we've already eaten. Right? So a lot of these gastric reflexes, have to do with giving us, dealing with what we already have and not what? And not eating more stuff, right? Cholecystokinin, I already told you, we've talked about this a lot, and here it is for real, okay? What does the word mean? Break it down. Cholecyst, gallbladder kinin, movement. We're going to squeeze the stuff out of the gallbladder because we need it now. And what does bile really do? I know you haven't talked about it, but what does it do? Does anybody know?
Breaks down fat.
Emulsification of fat, right? It's going to help us really start to break down that fat. In addition to what else is in the stomach that's been activated now? Lingual lipase, right? Lingual lipase. Made in the mouth, activated in the stomach. So we're breaking down fats now, for real. All right? Also, cholecystokinin. Why would we care about it slowing gastric emptying? Say that again? Because chyme's moving in, we need time to squirt all this stuff out, and for it to have time to produce its stuff and to absorb everything. So we don't want it just rushing past, right? We don't want gastric motility to be too fast. So we're going to slow down the release of everything through the pyloric sphincter so that it goes in a controlled manner, I guess if you will, and allows everything to mix together the way it should. Right? Really, that's what's happening. This chemical digestion, is squirting this stuff, pancreatic juice, small intestine juice, brush border enzymes, it's putting it into the mix, and then it's working as it makes its way through. Needs to have time to do stuff, all right? And then again, pancreatic juice secretion and gallbladder contraction. So really, that hepatobiliary pancreatic tree all works like in unison, or it should, right? So we squeeze the gallbladder, we make the pancreas release its stuff, it meets through that sphincter that we're going to discuss tomorrow, right in the duodenum, opens in, it mixes in with the chyme and on its way. Okay, does that make sense? All right. And then again, stop eating. Tons of fun, right? You have food already. We're digesting food you just ate, stop eating. So it promotes satiety, all right? K cells make GDIP. We've talked about GDIP briefly before in the endocrine lecture. Okay, again, why do we need it to do this? Insulinotropic peptide, what does that mean? Makes the pancreas make insulin. From which cells? Beta cells, right? Why do we need insulin? Because we just put sugar in the system, right? We need to use it, okay? Right, exactly. And what does gastrin help us do? Helps us make hydrochloric acid, that's right. And so, why do we not need any more hydrochloric acid? Because we've already eaten and we're dumping contents now into the small intestine. So our hydrochloric acid content can go back down, right? It's a sort of a retrograde effect, if you will, okay? But, does that make sense, everybody? Okay. And then miscellaneous stuff. Try to guess what absorptive cells do. Yeah, absorb stuff. Hell, I'm surprised they don't have some weird name, some weird eponymous name from somebody who discovered them. But absorptive cells, there you go, good enough. Goblet cells, just like in the stomach, make our mucus. We still need protection. Even though we're secreting bicarbonate, and even though the gastric contents are now relatively alkaline compared to pure hydrochloric acid, it's still acidic. Okay? It's still acidic, so we still need protection on the mucosa. And then Paneth cells, as clean as we all think our food is, it is not. So these things have lysozymes which help eat any bacteria and nasty bugs that we put into our system. Okay? Any questions about the mucosa and the histology thereof? Okay. Small intestine has plicae circularis. It's probably on the slide. I haven't memorized these yet, but what do you think plicae circularis help do? Even more surface area and also help us with peristalsis. So both correct, right? Both correct. So it causes essentially a spiraling of the chyme to make it come in contact with more of the surface area versus just a straight tube that it goes through. And so it helps come in contact with more of that surface area, which helps increase absorption. Okay? It's going through a spiral, think of it that way. And then we've talked about the villi. Listen, you don't need to know this. I'm not going to ask you how many villi per square millimeter, because I don't care, and probably because it's highly variable. So don't worry about that. Just know there's a lot. Okay, like I said, basketball-sized surface area. But it does look, this is true, it does look like velvety when you look at the inside of the small intestine because of the villi and the microvilli. Anybody ever watch Looney Tunes? Doesn't this look like the end of Looney Tunes? Like that's all, folks? Right? Yeah. So this is plicae. These are plicae circularis of the small intestine. These folds. As this stuff makes its way through, it kind of spirals its way around so that it comes in a surface area with the majority. Because again, gravity is gravity, but the absorptive cells aren't just at the bottom. We're going to use that surface area by making it come in contact with the whole thing. All right? Does that make sense? There you go. Villi, microvilli. I don't know how much more I can talk about microvilli. You guys got it? Okay. Where else do we have a brush border? I think I already asked this question, but where else? Huh? Proximal convoluted tubule, right? And what is the responsibility of proximal convoluted tubule? Absorb most of our stuff, right? And so similar physiology. Different thing, similar physiology, right? Increases the surface area so we can absorb all the stuff we need to absorb out of here. Easy, okay? So let me give you a clinical correlation that's not in here. Anybody ever heard of celiac disease? Okay, gluten allergy, gluten-sensitive enteropathy. What is an enteropathy? It is a disease of the small intestine. So what happens for a patient who has a true gluten allergy is they have an autoantibody that flattens the brush border. It flattens out the villi. All right, so what you have, instead of a tube that has this velvety appearance with all of this surface area, you have more of a flat tube. So what do you think is the problem with gluten-sensitive enteropathy? A lack of absorption. So these patients will suffer from malnutrition because they're flattening out. So it's the gluten sensitivity that actually causes it, but then you have this patient who's not really able to absorb any real nutrition or enough nutrition. So you have these patients who are actually physically losing weight, having signs of malnutrition because they're not being able to absorb what they have. Okay, so when we diagnose gluten-sensitive enteropathy, if the patient has been gluten-free because they self-diagnose often, we will make them eat some gluten so that when we do a biopsy, we can actually see the flattening of the brush border. Because if they go off gluten, that's the cure. Everything comes back up. So if we do a biopsy when they're already gluten-free, we're not going to see what we need to see. So we need to see the pathology so they have a gluten challenge, take a biopsy, see it, and then diagnosis. Honestly, whether that's always done is 6 of one, half a dozen of the other, because the patient's off gluten and they're feeling better, then why cut a hole in their stomach if we don't have to, right? You know what I mean? So we don't have to cut a hole in their stomach. You know what I mean? Why stick a tube in their throat? So that is the importance of the brush border, and that's a pathology associated with it, right? So we're just flattening out. That surface area goes away. We lose the ability to absorb our stuff. It's always funny to me that of all the terms we could use, we use juice, intestinal juice, pancreatic juice. Seems very non-medical of all of the thing, but that's what we call it. All right, and it's just the mixture of all of the stuff, the brush mortar enzymes, collectively, enzymatic or intestinal juice. All of the enzymes reproduce pancreatic juice. Okay. Anyway, so it does secrete a lot of fluid, right? A lot of fluid is secreted into the lumen of our small and large intestine. Okay. Which is partially why diarrhea can be so risky, right? We all think about diarrhea in our population, relatively healthy, your population, relatively healthy, right? We think about diarrhea and fluid loss and fluid shifts in an elderly person or in an infant, right? So we always think of diarrhea as sort of this benign, we get a profile, we don't do PT this morning process, but it really can, depending on your patient population and their comorbidity, be very, very serious because of the amount of fluid that exists in the GI tract, okay? So these are the brush border enzymes, okay? So what we talked about before, essentially hormones, right? Paracrine hormones, right? Autocrine hormones, things that are taking effect of similar or close to, right? But now we're talking about actual enzymes. These are the products that we use to digest. All right. Pancreatic amylase. So what's an amylase?
Carbs.
Carbohydrates, right? This is the real workhorse of carbohydrate digestion. What else? What other amylase do we have again? Salivary. Okay. But this is the real workhorse. Right? Particularly because salivary amylase kind of gets killed when it gets to the acid in the stomach anyway. All right. What this is saying is that amylase, like we talked about the very first day of this GI stuff, is that starches can't be broken down by amylases, like fiber can. So like the husk, like psyllium fiber, the things that we think. So that indigestible, insoluble fibers make their way through, and they don't really get affected by the amylases themselves. Okay, so fiber is a large component. Non-digestible material is a large component of what makes up feces. You probably already knew that. Waste products. Pancreatic juices. We're going to talk about pancreas tomorrow, so I know that this doesn't make a whole lot of sense now. And so we're going to talk about this. Though that right there is the majority of what does the work of our real protein digestion. Okay, so suffice it to say that for now. We'll put the finer points on it when we talk about what is pancreatic juice tomorrow. Okay, fair enough? And then lipids, pancreatic lipase, again, is the big player here. The big player here. Yes, does it start in the stomach? Yes, it does. But lipase from the pancreas is the real major player for true lipid digestion as it makes its way all the way through the small intestine. Okay? Questions? And then water, like I said, this much water goes in, this much water should come out the very end, but you see how much of that is absorbed in the small intestine, right? We always think about, because we know physical manifestation of water absorption is what? Constipation, hard stool, right? But really most of that water is already taken out by the time it gets to the large intestine. It's because relatively the large intestine is a lot shorter. So the transit time through the large intestine is a lot quicker. And so we don't have time to really absorb liters of water while it's there, okay? And what's the mesentery? Part of the, sounds like 4-syllable, five syllable, sounds like peritoneum, starts with a P, peritoneum, there you go. All right. And whoever was asking, is it highly vascular? It is significant, highly vascular, right? That's what most of these are, vascular. So again, feeding small intestine, all right? Questions about the small intestine? Okay. Now the large intestine. Absorption happens here for sure. Okay, absorption definitely does happen here. And really, what are we doing? What is the majority of the job of the large intestine? It is to get the rest of that water out form solid feces so that we can conserve as much water as possible, right? Again, we're trying to conserve water. The body is trying to keep as much of the valuable stuff that we need. All right? I want to call your attention to like surgical regions, right? Because everybody, if I say what are the parts of the colon, what are you guys going to say? Ascending, transverse, descending, right? Not necessarily. That is a part of the colon. But if we're talking about the large intestine, the major parts are the cecum, the colon, the rectum, and the anal canal. So disassociate large intestine from colon briefly, at least while you're in here. Does that make sense to everybody? Okay? Because what happens is the colon then is subdivided into those regions I just talked about. Okay? And if that doesn't make sense now, just wait for a couple slides and we'll get to it. So here is that ileum. So we're coming in here to the terminal portion of the ileum. This is called the terminal ileum. And then the ileocecal valve right here. And then again, this sort of blind diverticulum. It is a true diverticulum, outpouching. It is a vermiform appendix, meaning worm-like vermiform. And again, you can sort of see how stuff could easily just make its way into there. All right. And we'll call your attention to a couple other things here. Let's see. So, the hepatic flexure and the colon and the splenic flexure. Why do you think we call them those? Because the liver is here and the spleen is here. So it comes up, flexes, goes over, flexes again, and goes down. All right. Omental appendages, these little just fat pieces hanging off. The haustra are these outpouchings, right? So I told you that the myenteric plexus also keeps like a state of tonicity, right? We talked about how the GI tract in a dead person is significantly longer because we lose that tonicity of the musculature. The haustra, these outpouchings, are created by that, and they are facilitated by this thing called the tinea coli, which is essentially this band in the middle here. You see this sort of stripe that goes down the middle of the large intestine? That's the tinea coli, okay? And that's all in the slides. I just want to give it to you now. So ileocecal valve, sphincter, okay? We already talked about what that is. And the cecum is this larger portion. Like the actual physical diameter of the cecum is probably the largest in the entire large intestine. It's this big opening. It collects all this stuff and then moves it up. All right, peristalsis is still happening. People ask me, how come stuff doesn't go down into the vermiform appendix all the time? How come more people don't? Peristalsis helps keep it going north. All right, gravity isn't our friend in this case. And then sometimes, even if it does get in there, it is able to kind of work its way out. But there isn't really any peristalsis that happens in the appendix itself. It's a true diverticulum, just an outpouching. Okay. So, anatomy-wise, like I said, this is sort of the biggest pouch area, if you will. All right. And if you want to look at what this shows you on this side, for now, it doesn't matter. For now, it's just suffices to say that the appendix can be in multiple different places. It can be retrocecal. It can be all over the place. And if you get pregnant, it can go all the way up to here. So appendicitis in a pregnant female can actually present as right upper quadrant pain. All right. So all bets are off. But most of the time, it isn't one of the. It's hanging around here somewhere, but it doesn't always present exactly. So just know that, and then you'll learn about that in GI. Okay. This is what I was talking about. Obstruction of the lumen, fecalith. What does that sound like? Poop stone. That's exactly what it is. So you get that kind that go down into that little blind loop. It gets stuck there. It hardens. It becomes a fecalith. Then it creates outward pressure on the lumen of the appendix. Starts to impede blood flow through that pressure that's exerted. Eventually becomes necrotic. It gets appendicitis. If it's not relieved soon enough, it perforates, and then you have a peritonitis, okay? So where does it usually begin? halfway between the umbilicus and the ASIS, which is McBurney's point. Push down right there. Patient says, ow. That's a pretty good sign, right? Another clinical trick is like, hey, on the ride over here when it was bouncy, did it hurt? They're going to say, yeah. You know why? Because when you have inflamed peritoneum and it's moving around and squishing around there, people don't like it. So like the ride over, if they go over train tracks or bumps or something like that, they're going to be like, that hurts. It increases their pain. So there you go. It's the same thing. You guys learned heel tap yet? It's the same mechanism, except the car's doing it, not you. Okay? And then you go in there and you pop that little bad boy off, and they do just fine. That's as much as I know about surgery. There you go. No. So, now, this is what I was talking about. So we're subdividing the colon, okay? We're subdividing the colon into its different portions. Ascending, right? So the small intestine dumps in the terminal ileum right here into the cecum, and then it starts to head, it ascends, and goes up to what flexure? The hepatic flexure, okay? It takes a turn into the transverse colon, and takes a turn south at which flexure? The splenic flexure, and then down into the sigmoid and away from there, okay? So, ascending is retroperitoneal. What else is retroperitoneal? Descending, right? Yeah. Descending is retroperitoneal. Okay. And then the sigmoid, S shape. So we have ascending and a transverse, descending, and then our sigmoid into our rectum, and then our anus, okay? When now, if we do have a backup and feces sits here too long, then what happens? That's when constipation really becomes a problem. That's when our water reabsorption in the colon becomes a big pain in the ass. Anyway, so yeah, it just dries it out. More and more and more water is sucked out. It gets harder and harder and drier and drier and harder to pass. That's constipation. Okay. And now we come back to our old friend, skeletal muscle. As many of you know, you can't hold it. Okay. So we have smooth muscle on the inside, shouldn't be clear, right? It's just the end part of the smooth muscle transitioning in the anal canal to an external anal sphincter that allows conscious and voluntary fecal continence, okay? We'll talk about the pectinate line. Dentate line. Pectinate, dentate, why is it called different things? I don't know. Ask the anatomists, okay? What that is a transition point as we're going distally, so as we're going out, all right? We have pressure sensation, proximal, just pressure sensation. Then at that dentate line, we have a innervated anoderm that is now sensitive to pain and temperature, okay? So I'm going to go forward and come back. Right here we have this sort of line of demarcation, the pectinate line. On this side is just pressure, right? You feel like you have to defecate, but it doesn't hurt. Okay? Not true pain, not true temperature. On this side of the line, now we have pain and temperature sensation. All right? Does that make sense? This is the way it's innervated. Now you go back, we're seeing our patients, and they're complaining of rectal bleeding. Whatever color it is. One critical question to ask them is, does it hurt? When you defecate, is it painful? If it is, that leads us to believe it's somewhere external, past the dentate line, right? So we're thinking things like anal fissures, external hemorrhoids, something else, whatever. If it doesn't hurt, if it's painless rectal bleeding, now we're thinking it's inside the dentate line, internal hemorrhoids, polyps, worse things usually, you know what I mean? Painful rectal bleeding is usually less clinically significant as far as morbidity, mortality is concerned than internal or painless rectal bleeding. Okay, does that make sense? And again, you can see this anoderm right here is the the innervated skin of the anus. That's exactly what it is. It's the reason why it's highly sensitive and highly vascular, and it's the reason why it's the reason why hemorrhoidal tissue hurts when it gets enlarged. Okay, when it gets varicosity. You guys know what a varicosity is? It's a swelling of the vein. We talked about varicose veins in the lower leg, right? These are varicosities of the hemorrhoids. Hemorrhoids are normal anatomic structures. Hemorrhoids are not pathologic in and of themselves. Abnormalities of hemorrhoids are pathologic. What a hemorrhoid really does, or what the real function of these vascular beds are, is sort of to create a gasket effect, to sort of help maintain continence and leakage of bowel continence. Now it is blood flow, so it also has that obvious effect. When you have that hemorrhoidal tissue, it helps keep a gasket effect, so there is less likely of leakage. Because again, we don't just have solid material there, we also have liquid material there, so it can get out. So if a patient has an all the way around, sort of a circumferential hemorrhoidectomy, they can suffer from fecal incontinence, the inability, the loss of that gasket effect. They don't lose the external anal sphincter unless it's incised, and that's a whole other problem. But they will experience potentially even some anal leakage, even if it's done correctly. So that's one of the things you inform them about before hemorrhoid surgery. Okay? The reason why those hemorrhoids are so painful, again, it says it's below the dentate line, and it's swelling, this huge swelling and irritation of this very, very sensitive anoderm is very, very painful. Okay. So external hemorrhoid surgery is one of the most painful things you can send your patients to get. So make it your last resort, if possible. And again, like I said, hemorrhoids, should say varicosities of the hemorrhoids. The other thing that can happen is they can become thrombosed. All right, what's that mean? In layman's terms, huh? Clotted, yeah, clotted. That blood gets those varicosities, that's a lot of blood just sitting and pooling, especially in that area, sort of a gravity-dependent area. It can predispose them to clots, and then when that clot forms, it becomes very, very painful for that patient. Acutely, sudden acute increase in their pain, and that patient needs to go and get that thing evacuated, okay? So if you look here, these are hemorrhoids that are enlarged, right? Varicosity. Same thing here. So enlarged. You see that the venous plug, but this is normal. This becomes not normal, right? So it's hemorrhoidal tissue is a normal thing. Anyway, we're not going to go into the grades or the grading of internal, external hemorrhoids. It's not important for you now. What is important is which ones are going to be painful. External hemorrhoids because of the innervation. Internal hemorrhoids are going to be painless. Okay? A dentate, pectinate line, that's not just surgical anatomy, that's clinical anatomy, that's very important. Okay? All right. Now to histology, really, there's not a whole lot that makes this different. Again, same layers. The biggest difference here is that this muscular layer, the muscularis, has the tinea coli, which helps form the Hofstra package. So, think of that tinea coli is contracting, and it makes it pouches of Hofstra on the large intestine. Okay. Other than that, the layers really are about the same. Okay. Histologically, in the mucosa, we have more goblet cells. We still need the mucus there. Everything still needs the pack, particularly as it becomes more and more solid. It still needs to be slippery as it makes its way out. And also the mucosa of the large intestine still needs to be protected. Okay? And then we don't have the plicae circularis here. We do have the Hofstra. Okay, so again, physically looking at it, you can see the difference other than the size. Okay? Questions about this? Like I said, there's about a liter, a little bit less than a liter of water should make its way into the cecum. And as it makes its way through here, that is reabsorbed to where we get rid of maybe, what should be excreted in feces is maybe 100 milliliters of water, something like that, right? something along those lines. Not a lot should be excreted in feces. Any questions? Yes, ma'am. For a purpose? Absorption, not really, because not a whole lot of actual absorption happens. Any more that we're doing in the large intestine is really broken down by colonic bacteria. So there is some absorption. It is a little bit for surface area, for water reabsorption. So yes, in waters, but not like for the small intestine, if that makes sense. Yeah. It's a long way around. Yeah. Yes.
For the large intestine, is the serosa adventitia vary based on location in the large intestine?
Yeah. Let me go back. Where are we? So adventitia is in the. I can never keep it straight because don't worry about it. It's not important. As far as if I can remember correctly, the adventitia, it's one of them is retroperitoneal, one of them is peritoneal, and I can never keep them straight. But if I can't keep it straight, I'm not going to ask you to keep it straight because it's not that important. Really. It's such a fine point. So anyway, you got it for me? I thought that's what you were doing. Come on, man. You're like my court stenographer here. I need to fucking know what's going on. Right? All right, so we haven't talked about bilirubin cycle yet. We'll talk about it tomorrow. We did briefly mention that urobilinogen was what makes pee yellow. Further breakdown of that urobilinogen and that bilirubin in the gut turns into stercobilin, which is what gives feces its brown appearance. Okay, we will go through that entire pathway tomorrow. I will break it down as simply as I can. All right? So, and again, back to this. I think this is a prelude to your question. Chemical digestion, we're not making any more products here. There's no enzymes. There's no large intestine juice. Okay? There's just colonic bacteria. And that colonic flora is becoming more and more and more important as it becomes investigated. Like, so many things can be done by alteration. So many pathologies are root cause because of alterations of colonic flora. So we'll talk about that. I mean, one of the very least is inflammatory bowel disease, but things you wouldn't even think are related, things that aren't even really related to the gut per se on face value, can be altered by alterations and reseeding normal colonic bacteria. Okay? But we'll leave that alone. But just in case you wanted to know, this is really the stinky substance in poop and farts, okay, to use technical terms. And so, yeah, we don't, again, because the passage here, there's not a lot of space a lot of length relative to the small intestine. Only so much water should make it in, and about 100 milliliters of that should make it out. Okay? An increase in that water excretion is called what, typically? Diarrhea. Yeah. And feces becomes, when it becomes semi-solid, around the time it gets to the end of the sigmoid or so, is that really that important? But that's where it's technically called feces. And it contains a bunch of crap. All right. Flatus. This is produced from colonic flora and increase, decrease based on what we eat. We talked about FODMAPs with eruption and belching. It's the same thing. There are high gas producing things that then create additional flatus, especially let's say somebody is lactose intolerant. They don't have lactase, which is what breaks down lactose. But then when it sits in that colonic flora, it essentially ferments. And what's the product of fermentation? Gas, right? So these patients have a lot of gas, a lot of burping, a lot of flatus. It's one of the things. Every time I eat dairy, this happens. It's one of the things that helps us get to it. It's pretty straightforward, actually. Toxic megacolon, real fast. It's a dilation. A lot of times it's from Clostridioides difficile. Can be from, ulcerative colitis is another common cause. It is just literally a blow up of the colon. So toxic megacolon. Let's take this apart. Megacolon, what does that mean?
Big.
big, colon, yes, toxic, what do you think that puts on it? Sepsis, toxicity, right? And there's, what do you think the real risk of this guy is? Okay. Blowing up. All right, any questions about small or large intestine? We have some reflexes, some real quick stuff to do, and then we'll be done. Yes, sir.
Can you go back one second?
Sure can. Maybe. Yep.
So this is dilation from 4.5 to 8 plus inches. Is that saying 4.5 is the normal?
Yeah.
And then it can.
So there's a true criteria, like radiographic criteria of what the dilation is. It's larger at the cecum because the cecum is normally larger, and then it goes other places. So I can't remember if 4.5 is the delineation or not, but I can get you that real fast. But yeah, normally it's about 4 centimeters. Goes any larger than that. I think it's 7 at the cecum, but I can't remember specifically right now. But anyway, certain criteria I don't memorize. I just look them up when it comes time. But I'll find out for sure. Yeah.
You guys like in the large intestine, it says that one of the
Hold on, I can't hear a word you're saying.
it says one of the functions is production of certain vitamins. Where exactly does that happen?
To what? To do vitamin? Say that again.
The production of vitamins.
Oh. Where does it happen? Throughout, basically in the ascending and transverse, mostly. Not a lot of stuff happens in the descending portion or the sigmoid, but yeah. So, no specific area that I'm going to ask you. Really, what happens? A lot of the absorption of vitamin B12, a lot of the creation of vitamin K, it happens right around the cecum and the terminal ileum. That's where a lot happens. Because what happens is that if you have a person that has Crohn's disease, anybody heard of Crohn's disease? So Crohn's disease is one of the inflammatory bowel disorders. One of the places it attacks is the terminal ileum and the cecum. So that patient can have chronic vitamin malabsorption for vitamin K and B12. So it's happening around there. Other things that do happen in the large intestine that we don't need to really get into is absorption of things like iron. Right? Absorption of some minerals happens in the large intestine. Where it happens is not really important. Just know that it happens there. Okay. You will talk more about that certain area or those areas in GI, because then it affects like where this happens. If you have pathology there, then now you have a potential for a nutritional deficiency. So, but yeah, that's where most of that stuff happens, is sort of in the ascending, maybe a little bit in the transverse, but right there. Yeah. Okay. Any other? Yes.
What's your take on the historical significance of the appendix function?
Well, it supposedly has an immunologic function, but I mean, most, it's hypothesized that, there are immune problems subsequent to an appendectomy, but I just haven't seen it manifest, but then again, I don't do the research. I mean, in every patient that I've had that's had an appendectomy, they've been just fine. So I think it's a vestigial organ, but I mean, that's just my opinion, you know what I mean? So, anybody else? All right, do you want to take a break, or do you want to go through? We got 20-ish more slides left. You guys want to take a quick pee break? Go to the bathroom? Okay, go for it, yeah. Yeah, go to the I thought I put this on there, like, where we have a little thing here that has a little bit. It should be on the, let me know if it's not on the, it's not, I mean, it's would you know how the what? I thought, yeah. Here, I'll show you. Let me know if you don't have my, I'll low light.
I solved it.
It'll just say May.
The Dober that whole bottom is not select. So like, so you have select, ultimate, and then everyone else who got boarded. So and then you're just everyone who's not boarded is on the AML. So if they somehow go through all the alternates, they work off that all now. But they don't see where they don't, if your name isn't on it, then you have to
What's healthy is something.
But not increase. Like it's like past the
Well, I mean, I have dropped out. At this point, it's I have. Kids going to college and they have to get them married. They have to get them married. Yeah. back in the car.
Other way.
Are you enjoying this, Alex?
I always think about it. I just never do it.
Yeah, it is.
Well, that's kind of hard.
Yeah. All right. All right, everybody. Shall we finish this up? You guys can go study A&P Ii. All right. So, any questions about anything we talked about? Anything unclear? Or any further clarification necessary? All right. So let's talk about some of the inherent reflexes. Okay. So we talked about peristalsis. Essentially, without the slide, what is peristalsis? the forward propulsion, right? The forward propulsion of the bolus, right? So contraction behind it moves it forward, and so on and so forth. We also have segmentation, okay, which is more of a mixing movement, which kind of, remember yesterday I was talking about smushing the bolus? That's really further of that going on in the small intestine as it moves forward. So we're breaking stuff further up. There is some mechanical digestion that occurs in the small intestine, okay? So think about the bolus, like peristalsis, as just that forward movement, exactly what you guys just said. Squeezing behind it, moves it forward, and then again, and then again, and then again, right? Whereas segmentation is sort of moving the bolus forward, but also breaking it down. So it's not just moving the bolus forward, it's smushing the bolus again. So it's two distinct motions of the anatomy of the musculature, both essentially doing the same thing. So just think of the peristalsis is moving it forward. They're happening simultaneously. So peristalsis is moving it forward, so it's like the pushing from behind, whereas the segmentation is sort of the crushing it as it goes along. That's the easiest way to think about it. Does that make sense? Kind of? Yeah? Okay.
Sir, is there a big deal with the backward movement? Is peristalsis not allowed?
Well, there's retropulsion in the stomach, but most of the time we don't want stuff going backwards when it gets to the small intestine and pass. There is some forward and backwards, but the majority of the net movement needs to be forward based on that peristalsis. So that main contraction wave is happening behind the fluid bolus, so we do move it forward. We don't want it coming back the other way. Okay? Does that answer your question? Okay. Any other questions? All right. So motility, we talk about gastric motility, and gastric emptying time is something that we can measure, and we do in patients that have gastric motility issues or potential gastric motility issues. But right now, I don't need you to memorize how long it takes for a meal to completely empty the stomach. All right, that is not important now. Right? What is important is the general concept that the stomach just doesn't dump into the pylorus, right? Into the duodenum, it just doesn't dump, right? Because think of the size, the relative size of the stomach and its contents and its expansibility versus the relative size of the duodenum, that initial chamber of the small intestine. Very different, right? So it has to be released a little bit at a time. And that's essentially what the pyloric sphincter does. Not only does it prevent backwards flow, it also helps antegrade flow in segments. Does that make sense to everybody? Because if it just dumped out, you'd have increased gastric motility, you have something called dumping syndrome, and then you have a whole other set of problems that we're not going to talk about right now. Okay? Let's pull these reflexes apart one at a time. Gastroileal reflex. What do you think two parts it has to do with? The stomach and the ileum, right? What's happening in the ileum? At the terminal portion of the ileum? No, not what's there, what's happening. It's going into the cecum, right? It's going from the small intestine into the large intestine. Okay, so ileocecal valve is opening, right? So, as that happens, right? As we eat early in the meal, right? Early in the meal. So we're eating now, right? We already have stuff, we already have gastric contents, right? We're never fully clean or empty, right? So as we eat, the stomach, what does it start to do? It starts to make stuff. It starts to make hydrochloric acid, it starts to make all of those things. It starts to move, and like you were doing over there, exactly, it starts to move, right? It starts to begin the process of mechanical digestion. So it sends signal forward saying, open the ileocecal valve, let's let stuff through. Let's move everything forward. Does that make sense? We got more stuff coming in. Let's move the stuff we have forward into the large intestine. Does that make sense? Yes? Okay. All right, enterogastric reflex. What parts are we talking about? When we talk about entero, what are we talking about in general? Intestines. And gastric stomach, right? So, as we recognize, we being our body, recognize that our intestines are being distended, meaning what? Just in general. It means there's stuff in there. Okay? We inhibit stomach motility. We slow down gastric motility because there's already stuff in there, so we need to have time for the gastric contents to move forward. We need time to shuffle everything forward. Does that make sense? Okay? And then gastrocolic reflex, late in the meal or after we're done with the meal, right? We know that we've been digesting. Excessive stomach activity causes movement of the feces forward into the rectum. Meaning what? We got to clear out space. We got to get rid of the poop we already have, so we have space to make new poop. That's essentially what it is. Okay? Do those make sense to everybody? And again, first pass, you're not going to remember what it means just based on that. Just take some time. These aren't really not that difficult to keep together. If there's confusion, just please let me know. But right now, does that make sense to everybody? Okay. And then what do you think this one is? The urge to poop. It is correct. This is one of the things I could not bring myself to delete because Terry loved to tell everybody about the specific pressures that you can withstand before you lose it. All right? So if you get over 80 millimeters of mercury down there, it's about to go down, whether you want it to or not. All right? Don't remember those numbers, guys, please. All right. Yeah, and there you go. You know, there are all sorts of manometry tests where you can test that specific value. It is true, you can. You can do esophageal manometry, you can do anal manometry. Any place that's supposed to have a physiologic sphincter that withstands certain pressures, you can test with a manometry probe. So if you get into that, you guys, just let me know. I'll be interested to hear your stories. All right. Why do I have normal in quotes? Right. What's normal?
Average.
You'll ask, your patients will tell you, right? What's normal? Your patients will say, or they'll ask you the question, what is normal? I go to the bathroom this many times. Is that normal? Well, have you always gone to the bathroom that many times a day? Yes, then that's normal, right? Is a change. A change from your baseline is what we recognize as abnormal, AB normal, right? So if you have a sudden increase, sudden decrease, that may be a warning sign. But if you've always gone to the bathroom 4 times a day, then that's normal for you. If you've always gone to the bathroom once every 4 days, that is also normal. And there is a huge variance. The reason I say that here is because a lot of people think that there is a normal range. Like I'm supposed to have this many bowel movements a day. That's not the case. Okay? So when you recognize and you diagnose diarrhea, constipation, change from your patient's baseline, not some specific norm. Does that make sense to everybody? Okay. Diarrhea, increase in frequency, volume, or fluid, right? You guys have all had diarrhea. You know what I'm talking about? That's what it is. I used to go to the bathroom this many times. Now I'm going way more than that. Now I have diarrhea. Okay, good. But don't discount also if it's suddenly the same frequency but very watery, different consistency. That can also be diarrhea. Does that make sense to everybody? I used to go to the bathroom 4 times, very solid, normal, on the regular. Now I'm having the same amount of bowel movements, or maybe just 1 or 2 more, but it's watery and loose. That's diarrhea. Does that make sense? Okay, good. That's important clinically because you're going to see tons of this, right? Etiologies include tons of stuff, okay? Which is why the bottom here says numerous others. But you know what we really worry about in older people? Let's say you have a patient who's 50, 45 or older. All of a sudden, they develop this chronic diarrhea or chronic constipation out of nowhere. What's your big scare? This little guy right here. All right? Changes, like those polyps, as they get larger and larger, they irritate, spasm, change colonic motility, so patients might start to experience diarrhea. Normally, what do we think of? We think of constipation. Why? Because we think we have a physical obstruction. All right? Physical obstruction, if it's that big, it's a bad deal. A lot of times what will happen is the patient will present with diarrhea. That can also be a sign of neoplasm in a patient in the right demographic or with the right family history. Constipation, less frequent. We go from too much to too little. Okay? Chronic problem of age extreme. Babies, old people. Right? Babies are dry, old people are dry. What happens? It becomes harder and harder to pass. They suffer from chronic constipation. Or, more in the child realm, they have a hard stool. It causes what we call an anal fissure, which is an actual tearing in that anoderm. Then they have this fear of having that same pain again, so they hold it so long that it becomes constipated, potentially impacted. Okay? Anyway, that's it about constipation and diarrhea. Any questions about those two? All right, we have 2 more slides, I think. So, when you're old, you lose some of that defecation reflex, just like we lost some of that micturition reflex. So, what does it mean? Just to start with that, what does that mean to you? If you start to lose the urge to poop when it's time to poop, what does that mean? That means it's going to stay in there longer, right? So not just this insensate loss of fluid, but it's going to stay in there longer because they're not recognizing the sign to go when it's time to go. So if it sits in the erectile vault too long, what happens? It just compounds on itself, more water is reabsorbed, and they become chronic constipation. So there are multiple layers of reasoning. Multiple reasons is probably a better way to say that. Multiple reasons for chronic constipation in the elderly, okay? Also, elderly are on a lot of pain medications. What's one of the side effects of opioids? Decreased colonic secretions. And yeah, so we have all of these problems. Same thing. What's one of the best ways to cure constipation besides drinking water and taking fiber? Moving. Moving your body. What happens when you become elderly or infirm? You have decreased mobility. So again, all of these compounding on each other to create states of chronic constipation. Right? Let's see what else. Hiatal hernias are more common. Worn out diaphragm, man, just bust right through there. All right. Gastritis, just inflammation of the peptic ulcer disease, right? Specifically gastric ulcers. There's 2 different delineations of peptic ulcers, rather than the duodenum or the stomach gastric ulcers. Gastric ulcers more common in older patients. Anybody want to know why or guess why? What I just said, NSAIDs, right? They're on medicines. There are a lot of medicines that increase their susceptibility to that, okay? And then, you know, if you got a drinker, this isn't like you don't get old and just develop cirrhosis. You got to want it. All right. And then diverticular disease. Here's another one, right? And when I say goose eggs in a tire, does everybody know what I mean? Like the little bumps, the little outpouchings, like a weak spot that then forms like this outpouching. That happens in the elderly. Diverticulitis is, so, okay, let me just break this down. Diverticular disease broken down into diverticulosis, which is the presence of diverticulum, and then diverticulitis, which is an infection or inflammation of those diverticula. So what happens is, almost universally in an older patient, you will see these outpouchings just from chronic overpressure in the lower intestine, right? Oftentimes they're incidental. If the patient doesn't have any issues with them, you don't have to do anything with them. You don't have to wait, you don't have to do anything until it's time, you know, they have an infection or inflammation. So that's very, very common. And then again, when you really, so the guideline now is 45, which is not old. Thank you very much. But when you get to be 45, that's when we start doing prophylactic or preventive colonoscopies. All right, younger if you have a patient with a family history. So your timeline goes up farther and farther, right? Used to be 50, we've dropped it down to 45 because just epidemiologically, cancer of the colon is showing up in younger and younger and younger people. So I would not be surprised if by the time you guys have been practicing for a few years if it's not down to 40 or even younger. We're going to start colonoscopies. And then I discussed sort of the mechanism for this, right? All of those things, all of those compound features of the things that add further and further to hardening of the stool and constipation can ultimately lead to frank bowel obstruction or fecal impaction. Okay? And just a hint, if you ever have to disimpact somebody's bowel, stand to the side. Don't be like, it's gonna get you, all right? Anybody, history buff, anybody know what Napoleon's hemorrhoids have to do with Waterloo? So Napoleon had severe hemorrhoids, and before the Battle of Waterloo, he was not able to survey the battlefield adequately because he couldn't ride a horse because he had such painful hemorrhoids. And so, he had his Waterloo. Does anybody know what happened at Waterloo? That's the defeat of Napoleon and the fall of the French Empire. So now we have some anatomy and some history. I'll see you guys later.